I'm going to bank on the previous lecture of Dr. Eva when she talked about the many antiretroviral therapies that we have. So inaasahan ko po na naalala po natin itong lecture na ito. There. Okay. So just a review, this is the HIV life cycle. And these are the areas where our ARVs act upon. So I am expecting that we are all familiar with the types of ARVs, but let me review the names of the ARVs because these are the classes of the antiretrovirals. So these are the medications which are currently available in the country. Take note that these are our formulas for our regimens. We have our nucleoside reverse transcriptase inhibitors such as zidovudin, tenofovir, and abacavir, plus our lamivudin. And then our options for our NNRTIs are efavirenz, nevirapine, and rilpivirine. We also have a single protease inhibitor. And we have an integrase strand and transfer inhibitor, which is also for purchase. Okay, so it is important that we know the benefit or the impact of ARVs on life expectancy. No? As we move forward in time and as the medications become better in terms of efficacy, we note that the lifespan of people living with HIV becomes longer and longer. And this is good. No? Bisabihin, we can have what we call a functional cure despite not having an actual cure. And also with the what we call research and development, we have an evolution and almost yearly discoveries of new drugs. So science has evolved and we are now getting better treatment options. So when we say better treatment options, we're not only talking about the potency or the effectiveness of the drug, which ultimately, ang goal lang naman niya is to suppress the virus. But also, we're looking at better drugs in terms of less toxicity. So this is later on, I'll tell you about the concept of drug optimization, wherein we not only think of it works and we can become virally suppressed, but also the patients feel better. No, it means that the meds are less toxic, it is easier to take, and therefore ensures compliance with our patients. So habang tumatagal, nagiging better. Yan. So ito nga yung evolution of our drug paradigm. We started from many pills to a single tablet regimen containing all the effective pills. Recently, we have dived into the integrase strand inhibitor era, and there are recent discoveries of long-acting injectables, which mean that you get one shot, and that shot is good for many weeks. So, di mo na iisipin siya. It means, again, better compliance for patients. Now, the antiretroviral trials, through time, have shown na we get better and better virologic responses, meaning super effective siya. However, the studies on safety and tolerability of drugs nagdadwindle. Okay? So, kumbaga, we don't focus too much on the safety and tolerability, which we should actually do in parallel with virologic response trials. Okay, so the question which will launch our topic today is, why do people living with HIV stop their meds? No, this can be divided into individual reasons, systemic reasons, and structural reasons. The topic that we will be focusing on here is, of course, the effect, no? Effect ng mga gamot sa kanila. And, but somehow, in a patient's life, hindi lang talaga side effect ng gamot ang involved sa pag-stop ng meds. Kumbaga, life happens, and that is the reason why people stop. And side effects are only a part of it. That's the reality of life. Now, what's important to know is, what are the consequences of stopping ARVs? Of course, if you remove the suppression of the virus, you will now see viral replication, which will predispose the patient to be infectious, and therefore that's your public health problem. It also will increase inflammation, which will then affect the organs that are not initially concerned with HIV, like your heart, your kidneys, your brain, and your liver. Pero because of the chronic inflammatory process of HIV, they become affected. And of course, nawawala na ngayon ng ating ability to suppress the virus. So the resistance also of HIV becomes an important thing to consider. So if possible, we should really avoid patients stopping ART. But if we don't think of the long-term or short-term complications of the medications, this is a reality. Okay, so most ARVs have prominent side effects. This can be short-term side effects and long-term side effects, which decline in the quality of life and the treatment adherence of patients with ARVs. So almost every organ in the body actually reflects an effect of our ARVs. So it can be short-term, like diarrhea, rashes, etc. But sometimes, even people who have been on ARVs for months and years, dun palang papasok yung ibang mga side effects, which we will discuss today. Okay? So it is important to remember that side effect is an independent risk factor associated with poor compliance to ARVs. Poor compliance leads to, like I said earlier, lack of viral suppression, emergence of resistance, occurrence of opportunistic infection, and systemic inflammation. We know this story all the time, no? So sometimes the patients will just discontinue their medications because they cannot take the side effects anymore. And one common scenario is the discontinuation of efavirenz as a first-line treatment. We all know that we are very dependent on this particular NNRTI in our national program. So if patients discontinue efavirenz because of a side effect, then mapipilay talaga tayo kasi almost siguro more than half of our patients here are on efavirenz. But this discontinuation is a reality in the real world, no? They either discontinue it because of the rash, because of the nervous system symptoms, or the emergence of psychiatric disorders. And this is also a reason why patients often shift to the second line. Many medical studies have shown that the side effects of drugs actually affect heavily the adherence and quality of life of patients. It is also expensive for healthcare facilities to address the safety monitoring of adverse drug reactions and the treatment itself. So in rural areas and study in China, the cost of treating adverse effects is about 30% of a farmer's net income per year. So can you imagine how much is spent just to address these conditions? So when we talk about ARVs, we should talk about not only efficacy or if the drug works, but also the safety profile of this drug. However, when they do drug research and development, often the safety and the durability of drugs aren't quite present during the time na super hectic drug studies. These only occur later on in time. We will know after a few months, after a few years, if it's actually the toxicities are reduced. Is it actually convenient for the patient to take? Does it actually increase the resistance barrier? How is it with drug interactions? Is it safe to use in a general population? And is it safe in the long term? Okay, so now that we talk about the generalities of long-term complications, let's go now to the particulars. Okay, so several factors predispose individuals to adverse effects of ARVs. So these are the things you should consider when you're trying to rule in and rule out differentials. Number one, are there concomitant use of medications which may overlap with the current ARVs or may even have additive toxicities? That's one. Number two, are there comorbid conditions that increase or exacerbate the adverse effects? Example, Is your patient suffering from alcoholism? Or does he have a co-infection with viral hepatitis, which may increase the risk of hepatotoxicity? Does your patient have a psychiatric disorder, which may be exacerbated by efavirenz or integrase strand transfer inhibitors? Does your patient have an underlying renal dysfunction, which can increase the risk of nephrotoxicity from tenofovir? Also, something that you should consider is, are there drug-drug interactions that may increase toxicities of ARV drugs or concomitant meds? Are there genetic factors that predispose patients to abacavir hypersensitivity, efavirenz neuropsychiatric toxicity and QTc prolongation, and atazanavir-associated hyperbilirubinemia? So, before natin i-pinpoint na, okay, itong drug na to ang solo na may kasalanan kung bakit the patient is suffering from this condition, we think of the patient's past medical history, current meds, all of those things. Kasi pwede siyang synergistic to cause the effect. Okay, so first, let's discuss bone density effects. So this particular decrease in bone mineral density leading to osteoporosis is actually attributed to tenofovir. Okay, it's the TDF format, not the TAF. So TDF and sometimes protease inhibitors may cause osteoporosis. Now, osteoporosis increases the risk of fracture. So in a study done with patients who are on 2 years of ARV, it was shown that when they did a bone scan, the density actually decreased by 2 to 6%. Bone mass loss in those on ARVs was 2.5 times that in non-treatment group. So the question is, should you do a baseline bone scan or a yearly bone scan in patients who are on these drugs? Ang sagot ay, it is not cost efficient. So it will be really up to you. If you think that your patient is at increased risk for developing osteoporosis, for example, menopausal, or meron siyang history of pathologic fracture before, then probably tenofovir and PIs might not be the best drug for your patient. So what are the treatment strategies if patients have osteoporosis from TDF? You can monitor your BMD more regularly, and you can give nutritional support treatment. So we have our alendronates, which can increase our calcium stores in the body. Bone marrow suppression. So this is a common long-term side effect of our zidovudin. So often we see this as anemia. What kind of anemia? It's a macrocytic type of anemia. So if you look at your patient's CBC count who are on AZT, usually yung MCH nila ay mataas. Okay? But if you see their hemoglobin, this is long-term ha, sabihin na rule out nyo na yung acute anemia as a cause of side effect from zidovudin. Ito yung mga hindi anemic pero naka-zido for years. We can see that their hemoglobin is fairly normal. Yung MCH lang nila is big, macrocytic. So here we have a study that shows that there is an increased rate of anemia, and if combined with nevirapine, leukopenia in patients who are taking zidovudin. So how to treat? You must monitor your blood test regularly. You should avoid co-administration with drugs that induce bone marrow suppression. And of course, if it needs, kailangan natin mag-switch. So later on, I will teach you switching strategies. Next, we have cardiac QTc interval prolongation. So this effect is most often reflected by the drugs efavirenz and rilpivirine. So ano ba tong QT? So if you look at your ECG strip, here we see na yung QT interval natin is prolonged. What happens if your QT is prolonged? It's a type of arrhythmia that can actually end in sudden death, but it can be preceded by seizures, loss of consciousness. So it's important that if you have a patient who reports some cardiac underlying pathologies, baka kailangan niyang mag-baseline ECG and quite frequent monitoring if they are on efavirenz or rilpivirine. Okay, next, cardiovascular conditions such as myocardial infarction, and stroke. So this is seen most commonly in patients on abacavir. So sometimes even on COVID-boosted PI or efavirenz and elvitigravir, pero most commonly talaga abacavir. So if you have a patient who is suffering from past MI, cardiomegaly, arrhythmia, past stroke, please avoid giving abacavir to these patients. So in studies, we have seen that the incidence of myocardial infarction or heart attack or CVD after taking abacavir was 3 to 6 in about 1,000 per population. The incidence of MI in protease inhibitors group was about 5.1 per 1,000 population. The first 4 to 6 years of medications were accompanied with an annual increase of 26% myocardial infarctions compared to the risk. I mean, compared to those who are untreated, parang 2 times more likely to suffer from heart attack ang isang tao na naka-abacavir or naka-protease inhibitor. Okay, so let's just please assess at baseline yung cardiovascular risk ng mga patient natin. Yun. So, we should do regular blood lipid and glucose monitoring. If we see some abnormalities in our patient's medical labs and history, we should always recommend change of lifestyle or medications if needed and symptomatic treatment. Okay, later on, I will show you what things you should monitor on a schedule as advised by our national guidelines. Okay. Next long-term side effect is dizziness, suicidal ideation, abnormal dreams, depression. So things that concern your central nervous system. And often, these side effects are brought about by efavirenz and at a lesser extent rilpivirine. So, ano bang merong ebidensya? So, efavirenz was associated with an increased risk of suicide compared to those who do not actually take efavirenz. So, meron silang 47 events compared to the 15, no, of those people who are not on efavirenz. So, if we kind of nitpick the patients who are on efavirenz, here we can see that some of them have history of psychiatric conditions or are currently having psychoactive medication. So please, again, explore your patient's history. Ito po yung napansin ng IAS study recently na ang ating mental health screening is actually very low in the Asia-Pacific region. So I think because of this fatal side effect of efavirenz, we must pour more attention on actually screening our patients for mental health conditions. So mental health day yata kahapon, so this kind of drives the point na we should have some sort of screening among our patients. I think the shortest possible screening for mental health is the mini mental state exam, MMSE. Those are, I think, 7 questions. I started doing that here in the clinic, yung tipong may instructions, no? Fold the paper and then follow what's inside and then copy the pentagon, stuff like that. There you can assess whether you should explore more your patient's history of mental health. And if they do, then I think it is best not to give efavirenz as their first line ARV. Okay, so exploring more the side effects of efavirenz, here we see that, so these on the pie on the left often are what they call short-term side effects. So let's look at the psychiatric effects on the right. So here we see severe depression, suicide ideation, suicide attempts, aggressive behavior, paranoid reactions, and manic reactions. So yan yung mga you need to elicit from your patients if they are at risk. So that makes this article very funny. It says, has the time come to abandon efavirenz for first-line antiretroviral therapy? So to continue our list, Hypertriglyceridemia. So since Dr. Kawili of Makati Med will be lecturing on the metabolic side effects of ARV, anything metabolic I will skip. Okay? Kasi ili-lecture to ni ma'am. Hindi ko siya uulitin. Okay, so insulin resistance, she'll also lecture on that, so I'll skip it. So let's discuss lipoatrophy or hypertrophy. These are conditions which patients on second line treatment are most afraid of. So if you have patients on lopinavir, ritonavir, ito yung nababasa na sa internet na I'm afraid of what I will have, no? I will have changes in my fat distribution. So what does this really mean? Ito siya. So you have an incidence of 8.6% fat redistribution among patients who are taking protease inhibitors. So this means fat deposition in the tummy and dito sa likod, buffalo hump and malaki yung chan. Whereas if your patient is taking zidovudin, they have a loss of fat. They have lipoatrophy, often in the temple area and in the extremities. Okay, even efavirenz at a certain level can cause fat atrophy. So in areas where merong fillers, no, as we discussed last week sa ating derma lecture, they can inject, which can minimize the fat atrophy in the cheeks. But this is short-term effect, mga 6 months, no? 4 to 6 months lang yung duration ng fillers, and they have to start it again. Okay, next, renal effects. So we have tenofovir, the TDF, not the TAF, as a culprit for this. And there are actually different types of renal problems. For TDF, it is a proximal tubulopathy, wherein you can see a progressive decline in your GFR and excretion of phosphate. Okay, so makikita natin na wala namang ibang cause, pero bakit bumababa yung glomerular function rate ng ating patients? And there's hypophosphatemia because they are excreting the phosphates out in the urine. And if you have low phosphate in the body, you will have osteoporosis in the future. So that is why patients on tenofovir cause decreased bone density because you have hypophosphatemia from the kidneys. Now, other kidney effects include stone formation, no, nephrolithiasis. Often this is a cause of our atazanavir, okay? Also darunavir to a low extent. So patients who complain of masakit yung what's this likod, flank plus hematuria, you should probably look for stones, okay? And then interstitial nephritis can also be seen in patients who are on atazanavir. Now, we talked about the problems. Let's now talk about the solutions. So if we do have a patient with those conditions and we deem it needed na mag-switch tayo to another drug, we should think of the following. All previous resistance test results. Viral tropism, if you're going to use Maraviroc. If you want to use ABC or abacavir, ano yung kanyang HLA-B 5701 status? This gene confers an increase in an allergy to abacavir, which is sometimes lethal. Next thing to consider is adherence history. Of course, if you're going to shift a patient to a medication that entails more pills taken more times a day, you should balance that out with the propensity of the patient to skip or forget medications. Next, does the patient have prior intolerance to any ARVs? And list down all the concomitant medications and supplements for potential interactions with your new drug. So yan yung mga itatanong nyo muna sa baseline bago tayo mag-shift. Ngayon, what do you want to shift to? Okay, going back to our list earlier. Number 1, if your patient was on tenofovir and now you noticed bone density effects, osteoporotic na siya, so you want to switch it, you can either switch to abacavir or the TAF type of tenofovir. If you have bone marrow suppression resulting in anemia in your patient on zidovudine, you will switch to TDF, TAF, or abacavir. If your patient presents with cardiac QTC interval prolongation from efavirenz or rilpivirine, you will now shift to a PI or an integrase strand transfer inhibitor-based regimen. If your patient has a risk for MI or stroke, and ang old drug niya ay abacavir, you should shift to tenofavirs, emtricitabine, and lamivudine. If galing siya sa PI, you can give dolutegravir, rilpivirine. If your patient is prone to having CNS side effects from efavirenz or rilpivirine, you can give etravirine, PI, or integrase. However, in the Philippines, ang first line natin na gagawin as recommended by our local guidelines is if they're on efavirenz, you can shift to rilpivirine after having an undetectable viral load. Okay, next, if your patient develops increased triglycerides because of this drug, you can give them either your integrase strand inhibitors or your rilpivirine. Okay, if they have insulin resistance from your protease inhibitors, you can give your integrase strand inhibitors or rilpivirine. If your patient manifests lipoatrophy from zidovudine, so wala nang stavudine, so let's erase that, you can give tenofovir or abacavir. If your patient has lipohypertrophy, malaki tiyan, malaki batok, malaki yung likod, walang evidence of reversal on switch. So, papatanggapin natin sa kanila na, I'm sorry, but you will have this regardless of whether we switch or not. Okay? No evidence pa kasi. Hilaw ang ebidensya. If your patients have renal problems, so hypophosphatemia or increased GFR, on tenofovir of the TDF variant, you can switch to ABC or TAF as long as your creatinine clearance is more than 30. If you have stones and you think that talagang ang may kasalanan nito is atazanavir, then you can shift to others. Okay, now let's talk about monitoring. So how do we actually monitor if our patients have risk for these long-term complications? So according to the about to be signed new guidelines, these are the basic monitoring schedule. For those who are on tenofovir, please do a creatinine within 6 months of starting, then every year or as needed. If your patient is on efavirenz, you should monitor the lipid profile, which should include total cholesterol, triglyceride, low LDL or the bad cholesterol within 6 months of starting and then every year. Next, for those who are on zidovudine, of course, CBC. So the issue of zidovudine where bone marrow suppression is concerned is both acute and chronic. So pag acute, we can see a sudden drop of the hemoglobin, which is why the recommendations for doing CBC among patients who are on zidovudine are quite frequent at the beginning. No? 2 weeks, 4 weeks, 8 weeks, 12 weeks, and 24 weeks after beginning, and then every 6 months or as needed. So mas madalas tayo mag-CBC ha. Next, for those who are on protease inhibitors, we should do lipid profile and fasting blood sugar within 6 months of the start, and then every 12 months as needed. If you guys want, you can actually do these things in the baseline as well so that you have a point of comparison when you do your follow-up na tests. Okay, now let's talk about treatment optimization. How do we actually make the treatment more acceptable to the patient? If the patient is suffering from side effects of our drugs, we should think of these particular strategies. No? Different doses, different combinations, different formulations, newer drug classes. So as promised a while ago, I want to share with you the actual new recommendations of the World Health Organization with regards to the first line. ARV. So, background muna. Since 2006, the WHO has recommended that TDF, 3TC, or M-tricycline in some countries, plus efavirenz, 600 milligram, is the preferred first-line ARV for adults and adolescents. However, recently, the WHO recommended dolutegravir as an alternative option for first-line ART because of the uncertainty regarding the safety and efficacy of DTG during pregnancy and among people living with HIV receiving TB treatment with rifampicin. So ano ba to? So kasi is this dolutegravir, no? It's an integrase strand inhibitor. It was discovered that dolutegravir actually has some neural tube defects side effect among pregnant women. So what does new NTD mean? There were 4 cases of severe neural tube defects among 426 women on DTG periconception or before they got pregnant. So this means approximately 45% of all births. So ang frequency niya is 0.9% versus 0.1 among those who are not on dolutegravir. World Health Organization dati that dolutegravir should be the first line has now been relegated to the alternative option for first-line ART. Let's read the recommendations on first-line. A dolutegravir-based regimen may be recommended as a preferred first-line regimen among adolescents, women, and adolescent girls of childbearing potential. Very low certainty. Note of caution on use of dolutegravir during the periconception period and for women of childbearing potential. Exposure to dolutegravir at the time of conception may be associated with neural tube defects among infants. However, DTG appears to be safe when started later in pregnancy. After na mag-organogenesis, meaning 8 weeks after conception. Adolescent girls and women of childbearing potential who do not currently want to become pregnant can receive dolutegravir only if they have consistent and reliable contraception. Again, limited data on this. An efavirenz-based regimen is still a safe and effective first-line regimen recommended for use by the WHO drug guidelines and can be used among women of childbearing potential during the period of NTD. So, ibig sabihin, dead man, no? Babae na buntis, either first trimester or beyond, or has plans to get pregnant, safe ang efavirenz doon. So the national program should consider the balance of benefits and risk, including fertility levels, contraceptive ability and coverage, pre-treatment resistance, and drug availability, maternal and infant toxicity when selecting the optimal ARV drug regimen for women. So they did a head-to-head study between dolutegravir versus efavirenz, and they saw that dolutegravir was better tolerated than efavirenz, but they developed more insomnia. So, hindi makatulog sa gabi ang mga pasyente. Anong solusyon? You can take this in the morning. Now, where safety is concerned, here we see that there is, so dolu is the blue triangle, and efav, the 3-in-1, is the gold square. So here we can see yung incidence. So we want the left side, no, less incidence of event. There's more abnormal dreams with efavirenz, more rush with efavirenz, and all the other things. So aside from really insomnia in dolu, it was actually had a better safety profile. And there was less discontinuation among those who were on dolutegravir compared to efavirenz. And if you have patients who discontinue their drug treatment less, then that means they will be more compliant, less risk of resistance, and less probability for them to develop opportunistic infections. So, ang tanong, sa dolyo na to, maganda ba yung kanyang interactions with other drugs? So here we can see the only problem we have actually is rifampicin and metformin. There should be a dose adjustment. You should be able to give metformin at a lower dose. Okay, another strategy is reduced drug regimen. So napapag-usapan to among those people in research na we're talking about giving 2 drugs instead of 3 drugs, and also the long-acting drugs. Yan. So again, when we think of treatment optimization, we think of a lot of things. Is it cost-effective? How is it with the food intake? Will there be drug interactions? How's the palatability? How's the toxic side effect? Do I have access to this? Is it a heavy pill burden? Is there harmonization with the rest of my medications? As a take-home message, no, when we talk about chronic adverse reactions of medications, especially ARVs, we must remember that lifelong therapy is longer for some PLHIV than others, especially those who were diagnosed at an early age. So think about the kids who were actually born with HIV. They have been taking meds for their whole life. So we should think of yung mga effects ng gamot sa kanila kasi more exposed sila. So that ends my lecture today.